Hello, everyone, and welcome to the final webinar of the year. It's great to see so many of you joining us today in what's a very busy time of the year. I can see the people joining now, streaming in. Okay, so I'd like to get started because we've got a lot to get through. I will start by respectfully acknowledging the traditional custodians of the lands on which we all meet today and pay my respects to elders past, present and emerging. I'm joining you from Melbourne on the lands of the Wurundjeri Woi-wurrung people of the Kulin Nation. So today I'm going to give a quick presentation of the results of the study. Then I'll introduce the panel. We'll have a panel discussion and then open up for questions from the audience. So please type your questions for the panel in the Q&A box. You can also upvote other people's questions if you see a good one that you'd like to have asked. The Q&A box is at the bottom of your screen and looks like this. And also just to let you know that this session is being recorded and will be shared on our website. For those who don't know me, I'm Chris Elvidge. I'm the Head of Research at the Childhood Dementia Initiative. And this is the paper that was published in the November issue of the medical journal Brain. This was a very collaborative effort and several of the authors listed there are on the panel today. I'd like to acknowledge that not everybody in the audience is a researcher or a clinician and may not be familiar with what a burden study is. So just briefly, a burden study estimates the health impact of a disease or group of diseases, including life expectancy and the number of people affected. You can measure a lot of other things as well. There's a wide scope. So why is this important? Until we know the scale of a problem, it's difficult to adapt health systems to cater for those people. And it's also useful to have this data for advocating for more research funding, for example. I'd also like to mention that we are going to be going through some statistics that can be quite confronting and acknowledge there are real people behind these numbers. And we have families joining in the audience and on the panel today. So childhood dementia has received little recognition and unlike adult onset dementia is typically considered as individual rare disorders rather than by their common symptoms of dementia. So we conducted a scoping review to clarify the definition of childhood dementia and quantify the collective burden. So what conditions were included? We had a case definition, which is up on the slide there. It's basically any condition that causes progressive neurocognitive decline starting before the age of 18. And we focused on monogenic conditions, which are those conditions caused by a change to a single gene, because they cause the vast majority of cases in countries like Australia. Treatable conditions were considered separately, and they were defined as those with close to normal life expectancy, with assuming that there's an early diagnosis and stringent treatment. So we did a literature review and also searched a database called the Human Phenotype Ontology Database to compile a list of conditions. An expert clinical working group was consulted for those conditions where inclusion was unclear. And then we extracted data from the published literature, including incidence, life expectancy, age of onset and age of diagnosis. And health economists at Thema Consulting modelled the burden of illness. And we started with a list of 750 conditions, which was then whittled down to 170 conditions that were retained for data extraction. And these 170 conditions can be split up into three different groups. The group on the right, the treatable disorders, there were 25 of those. And they were, for example, urea cycle disorders and organic acidureas. And these conditions are generally included in newborn screening programs and can be treated with relatively simple and widely available interventions. So they were considered separately. And this left us with a list of 145 currently untreatable conditions 76 of these we couldn't find information on their incidence or their life expectancy. So they were unable to be included in the analysis, although they still remain on our list of childhood dementia disorders. They just weren't included in the calculations. And then we had a list of 69 conditions for which we had data for the analysis. And this was the focus of the study, these conditions. And if we look at how these conditions are classified, you can see in the left pie graph, a large proportion, 2/3, are inborn errors of metabolism, which can be broken down in the right pie graph, dominated by lysosomal and mitochondrial diseases. But as you can see, there's also a wide range of other types of conditions causing dementia in childhood. This is a snapshot of the main findings of the scoping review. The incidence was calculated to be 1 in 2,900 births, and this is similar to cystic fibrosis. And I'll go into the other numbers in the upcoming slides. The modelling allowed us to estimate the number of births, number of people affected at any one time, and the number of deaths, and a range of other statistics. For Australia, this showed that there were 107 births per year estimated, nearly 1,400 people at any one time living with childhood dementia, and 91 premature deaths due to childhood dementia each year. And I know that we have people joining us from all over the world today. So I'll go through, as another example, I'll go through the USA figures. So that's over 1,200 births per year, over 17,000 people currently living with childhood dementia, and over 1,000 deaths each year. I'm hoping there's some people joining us from Europe as well, but it's quite late there, so maybe they'll watch the recording. So with the gaps in data, we have to be clear about what we can and can't say at this stage and how these can be extrapolated to other populations. We can assume that the incidence of childhood dementia is comparable in upper middle income countries. However, in countries without newborn screening programs for treatable conditions and limited access to specialist healthcare, it is expected that there would be a substantial increase in childhood dementia burden, and we estimated more than double the incidence. And these children would have a reduced life expectancy. So further research is needed to understand the impact of childhood dementia globally, especially in lower income countries. Now to delve a little bit deeper into the survival analysis that was presented in the paper. It showed that median survival is just 9 years. This means that half of children with dementia die by their 10th birthday. However, there's a wide spectrum depending on the disorder and even within disorders. Some children die in infancy, for example, those with Gaucher disease type 2, whereas some children will survive into their 5th and 6th decade. 29% of the children reach adulthood and only 10% reach the age of 50. From the survival analysis, we estimated 91 premature deaths each year due to childhood dementia in Australia. And for comparison, 92 children aged 0 to 14 die annually in Australia from childhood cancer. And these sort of numbers are replicated in other countries, as you'll see in the paper. But childhood dementia certainly doesn't get anywhere near the amount of attention and resourcing and funding as childhood cancer. In fact, our analysis has shown that childhood dementia gets 9-fold less research funding per patient from the Australian government, and there are 12 times fewer clinical trials per patient globally. We'll be publishing an updated report on this disparity early next year, so look out for that. So these statistics not only highlight the need for greater investment in the development of therapies, but are useful in planning services such as palliative care. The age of onset on average was 2.5 years, and the age of diagnosis is around 4 years. And we also collated some evidence of delayed diagnosis. There was a time diagnosis reported for 19 of the childhood dementia conditions, and more than half took 2 or more years to reach a diagnosis on average after the onset of symptoms. In 3 studies, the median time to diagnosis was 6 or more years. Now, we know that early diagnosis is not only critical to access appropriate care, but it also plays a key role in the development of therapies. Early diagnosis and intervention before the onset of irreversible brain damage gives the best chance of successful treatment. So expanding newborn screening programs and rapid and reliable diagnostic pathways for childhood dementia disorders are really needed. And now just quickly, all of the data in the paper, plus extra statistics about all of the conditions, have been put in a database called the Childhood Dementia Knowledge Base that anyone can access through our website. So why does all of this matter? The study shows the importance of grouping these conditions together to show the scale and impact of childhood dementia. This is in keeping with the approach to adult dementia and cancer, for example. The Dementia Australia website says that there are over 100 diseases that cause dementia. Yet there are services and health policies in place for all types of adult dementia. Similarly, a researcher might work on a certain type of neuroblastoma, for example, but will be classified as a cancer researcher and can access funding earmarked for a broad range of types of cancer. There is a groundswell of support for bringing these conditions together under the childhood dementia umbrella to gain economies of scale and improve outcomes for these children and their families. Patient organisations are adopting the term, and individual families are using it to raise awareness and understanding of their child's condition on social media and in the community. CDI was officially launched 3 years ago, and we are already seeing positive change, which I'm sure will come up in the panel discussion. I'd like to acknowledge everybody who contributed to this study, especially Nick Smith, for guiding the burden study right from the start when we started this work in early 2020. The clinicians who helped curate the list of conditions, especially Michelle Farah and John Christodoulou. David Thorburn for helping us with the mitochondrial disease group, which is notoriously complex, and the health economists led by Dominic Tilden at FEMA, who did this work for us pro bono. And of course, my colleagues at CDI. And finally, I could talk for another hour about the work of Childhood Dementia Initiative. But just briefly, CDI is continuing our work in 3 main areas: care and support, research and data, and advocacy and awareness. And they all converge on making childhood dementia a health policy priority and gaining access to treatments and cures and equitable and quality care. So now I would like to invite our panellists to turn on their cameras, and I'll introduce them. I'm just going to stop sharing my screen. Okay, so I'm going to start with Renee Staska, because the families impacted by childhood dementia are central to everything that we do at CDI. Renee is joining us from her home in Adelaide. Renee is a mother of 3. Hudson, who's 8, turning 9 this week. Holly is 7, and Austin is 5. Her youngest, Austin, was born with an enlarged spleen and liver, and when this didn't resolve, a gene panel revealed a diagnosis of Niemann-Pick disease type C. Her 2 older children were then tested and received the same diagnosis. Renee is a member of our family advocacy program and has made a great contribution to our work, including raising awareness through several media pieces and even accompanying us to a meeting with the Federal Health Minister. Next, I'll turn to 2 brilliant paediatric neurologists who were involved in this study and are members of our Scientific and Medical Advisory Committee. Nick Smith was senior author on this study and is a consultant neurologist and the neurology department head at the Women's and Children's Health Network in South Australia. He has a specialist interest in the management of childhood dementia, and his research group at the University of Adelaide focuses on the development of targeted therapies. He's also a principal investigator on several childhood dementia clinical trials. Michelle Farah is a professor of paediatric neurology at UNSW Sydney and specialist child neurologist at Sydney Children's Hospital, leading the rare neurological diseases clinical and research programs. Michelle's team is focused on developing and translating innovative ways of providing the best possible care from the time of diagnosis through treatment and beyond to people with rare neurological conditions. Next, we have Dominic Tilden. Dom is a health economist and director of Thema Consulting, a leading health economics and reimbursement consultancy. We're thankful to Dom and his team for the number crunching that they did, which was no small task. And last but definitely not least, we have Megan Mack. Meg is the CEO and founder of Childhood Dementia Initiative, which is driving research, healthcare and policy improvements for all children with dementia. As well as her extensive professional experience as a management consultant, she draws on her personal lived experience of being mother to 2 children with dementia. Isla and Jude are 14 and 12 and have Sanfilippo syndrome. We owe so much to Meg for the progress that has been made to date for children with dementia due to her vision and strategic approach. Okay, I think everybody's sick of hearing me talk. I'm going to have a drink and start asking some questions. I've got some questions prepared for each panelist. We'll go around, but hopefully spark up some conversation. So I'm going to start with Renee. These statistics are useful for advocacy, but they are confronting, and we need to remember that the real families and children behind them. You've been so generous in sharing your story, and we're really grateful for that. Why do you think it's important to hear the family stories? And maybe you can give us a bit of insight into what the reality is like for you.
Sure. So I am here today as the face, just to represent families that are in the same situation as myself. I'm just an ordinary person. I'm not a doctor, I'm not a nurse, but I was thrown into this world, as many of us parents are, and we quickly become experts on our children, and we quickly know the condition back to front. I guess for me, this is a pretty confronting statistic from this collection of burden. My eldest son is turning 9 on the weekend, as you said earlier, and according to this research, his life expectancy is over. The average age is 9. So that's confronting to hear and to read. And I'm not the only one with multiple children who are under this same umbrella. And I guess we've been living in this world for almost 5 years now, and there hasn't been a lot of progress. So it's just really, I'm grateful to be part of this recognition as a health priority.
Thanks, Renee. I've got a question for Nick next. So this study showed a shocking median life expectancy of 9, which really shows the unmet need in therapies. Can you comment on why we don't have more therapies and what we need to do to develop more therapies?
Thanks, Chris. I mean, it's an excellent question, and I think as those that have joined us on this call would understand, it's a multifactorial question. There are a whole range of factors that feed into the lack of therapies for children and families living with childhood dementia. And first and foremost, I think one of the limitations has been historically recognition that these disorders exist, recognition of the need for managing children with these conditions. And that's for a whole variety of reasons. Collectively, as we all know, these disorders are rare, individually rather rare, but collectively as we've seen from the burden study and the data that you've presented, these conditions are as common as many other conditions that the wider population understand and know very well. The lay population knows about cystic fibrosis. They know about childhood cancer. Most people, when you speak to them about any of the childhood dementias, will firstly respond with, well, that doesn't exist. You know, that's a problem for adults, isn't it? Why are you even talking about this condition? And if indeed it does exist, this must be so rare that it only affects a small handful of people around the world. Well, that's simply not true. And so recognition of the need for these disorders has been a true lack across the research and clinical field for many years. And indeed, most importantly, across the health advocacy field, both from a research perspective and a clinical systems and care perspective, because without that recognition, funding of endeavour to understand more about these diseases and to provide and to pursue therapies for these diseases simply hasn't been a priority. The urgency hasn't been recognised, and one of the things that I'm most pleased about the work that has been presented in this paper and the work that the CDI is doing is drawing that really critical and vital attention to this need, drawing that from the lay public, from those around us, from the clinicians who may have never seen these diseases, you know, even amongst those professions who deal with childhood health. Many have not seen these conditions and so don't recognise the need. And indeed, importantly, across the research base from our researchers across many fields, and most critically from those who are funding those endeavours. So our government advocacy, both at the state and federal level, and indeed non-government funding, to really allow those that are working towards therapies for these conditions to make progress and to leverage the work that many excellent people are doing to the benefit of the whole group of children with childhood dementia. So to unpack that briefly, well, we need to understand more about these diseases. Whilst we understand bits and bobs and limited amounts about certain numbers of these diseases, I think we would all recognise that understanding many of the mechanistic processes, the biology, the actual goings-on at the cellular level within the body and the brain and the nervous system for children across this spectrum of diseases is really only fairly poorly understood for a vast majority of these conditions. And in order to be able to target therapies and to deliver therapies that are meaningful for children, we need to understand more about those diseases. And patients and parents are highly invested in working with clinicians and researchers to gain that information. And it's incredibly powerful to see and to discuss with families and have families invested in that work, because it's a collaborative effort. It's a team effort with us all working towards one goal. And that's been a really important aspect of this work as well, and something that's certainly within the Australian community we are starting to see evolve very much to the benefit of the wider childhood dementia spectrum. We also obviously need to look at how we can work together better for these diseases. And I think this is something that, again, has been historically lacking across the childhood dementia field and indeed across the wider life spectrum dementia field. There are many people doing really good work and excellent work in a range of conditions who have no knowledge of what people down the corridor are doing, or across the next state, or in another country working on these disorders. And indeed, bringing those people together, researchers and clinicians, most importantly families and communities, to look at the commonalities across these diseases. And indeed, that's commonalities of symptoms and symptom progression, but also commonalities of disease mechanisms, how these disorders actually affect our brain, is a really critical aspect of how we can leverage that work and that knowledge and that insight from colleagues across the country and across the world to benefit the wider spectrum of patients with childhood dementias. So a therapy that might be being looked at in one condition may well be beneficial for others. And that's a really critical and important focus that is starting to evolve within the field, and indeed is starting to show significant benefits across the field. And I'd highlight also that knowledge from the adult dementias is also really important for those of us developing therapies for children, because again, whilst we think of these conditions, or have to date thought of these conditions as very disparate, very separate diseases, we know increasingly that these conditions are in many cases linked and have very similar mechanisms of disease. And Chris, you mentioned a condition called Gaucher disease earlier, which is one of the childhood dementias. And indeed, a change in the gene that causes Gaucher disease is one of the commonest genetic factors for Parkinson's disease and Lewy body-related dementia in adults. So that's just one exemplar of the crossover between the childhood and adult dementias. So we want to bring people together, bring researchers and clinicians and families together to look at how we can tackle these diseases across the spectrum. And finally, what I would say, and I think this is critically important, and again is underpinned by the work that CDI is doing and the advocacy work that it's doing, is looking at how we can, as we develop therapies and promising therapies, or therapies at least with potential, how we can best assess those therapies and provide those to patients and to the patient groups, and to do that in a way that is meaningful both for individual patients but for the wider group and community. And I think that includes how we deliver our clinical trials and design our clinical trials. And one of the things that's really perhaps important for the people on this call to think about, and as we get together and discuss how we translate these therapies towards clinical trials, is which therapies obviously are those that are looking hopeful and promising, but also at what point in disease might we consider those therapies. And you highlighted this, Chris, by highlighting the need to diagnose these disorders as early as possible. It's critical for those of us working in this field to identify these diseases before they take hold, before they progress to advanced stages, because it gives us the very best chances for therapies to make a meaningful difference. And indeed, we see that through some of the clinical trials that we're involved with, where therapies have proved promising for a number of these disorders when given at a particular point in disease, typically early, but have had, unfortunately, very little effect beyond a certain point of that disease journey. And that's not to say that those treatments don't work, but perhaps that they're not working at the time point that they're given. And so that's a really important consideration that we all have to bear in mind here, and look at how we apply these therapies to the benefit of children, both singularly and in combined therapeutics. So there's a lot to achieve. There's a huge amount, and there's a huge amount to understand. And whilst that seems daunting, what I think is really critically important is that there's a groundswell, there's a change in how we think about these disorders that is being driven by CDI and this initiative to get together and to think about the commonalities of these diseases and how we might apply and translate those therapies and leverage that will that from all involved and that insight from all involved to develop these therapies. So it's a huge challenge. It's one that we are highly invested in, but I'm also very encouraged with what I'm seeing in terms of future activity in this space.
Thanks, Nick. You touched on it a little bit there, but Michelle, would you like to expand a bit more on the parallels and synergies with adult onset dementia?
Yeah, thanks, Chris, and good morning, everybody. It's a privilege to be joining today. So I think just reflecting, when we do hear the word dementia, we think of an aging population, but this study really highlights that although dementia may affect a large number of older people, it is not inevitable that it is due to aging itself. And there are many similarities and commonalities across the dementia spectrum. And it is a spectrum in terms of, even in an aging population, there's different mechanisms and different symptoms. But there's a spectrum of ages as well. But I think, coming back to your question, I think what it does share, as Nick has touched on, is biology mechanistic pathways. But I think as a clinician and a neurologist, what I recognize are also the many shared symptoms as well. And so we can approach research and care from many different ways, but when it comes down to what's important, it's how it affects a person and their family and the impact as well. And so what I see and what families and children with dementia conditions are living with is a decline in the ability to think, which is called cognition, problems with paying attention and concentrating. That can be very important going to school. Memory loss and difficulties learning, again, different for adults, but a school environment and an environment where you're growing up is very important, but also confusion, not knowing where you are. Behavioural difficulties, it can be disruptive, uncooperative, which is what I think we do see in an ageing population with dementia as well. Anxiety, fear, panic attacks, changes in personalities, immense changes in sleep patterns, changes in socialization and abilities to communicate and play with friends. So when you look at all those symptoms, you could think that I'm describing an elderly person with dementia, but I've actually just described a young child with dementia as well. So I think it's recognizing how confronting the statistics are, but how confronting the impact is as well clinically. And what that really says to me is we need to really think about, as a healthcare provider, how we can offer best practice care and support for families with what would really make a difference and what's important.
Thanks, Michelle. I can see we've got 3 questions coming in, so keep them coming. Don't be shy. I'll keep moving around the panel now. So Dom, the modelling of the burden of childhood dementia was quite challenging. Can you talk a bit about the challenges and how they were overcome?
Thanks, Chris, and thanks everyone for having me. Yeah, it was a bit of a challenge, but it was rewarding. I mean, typically these kind of studies in my line of work are done for like a single condition, or what's the burden of asthma, or what's the burden of cystic fibrosis or diabetes. I think the main challenge for us was just the volume. Like as you alluded to earlier and Nick repeated, you know, in the literature and in generally they're all individual conditions. So it wasn't a burden of illness study, it was 100 burden of illness studies in one go. And not only that, 100 rare conditions where, you know, typically, again, in our line of work, we thrive on data, but you need numbers to create data, and there wasn't necessarily a lot of that there. So in terms of challenges, I mean, what do you do? We could say, oh, this is too hard, let's not bother, let's just know that it's there and someone else will fix it. But I noticed Renee said, you know, it's important that these kind of conditions get to the top of some sort of priority list. And if you take that sort of attitude, you won't get there. So, I mean, what we did, and obviously you did a lot of this work, wasn't just us, is you do your best, collect those key important pieces of information that can help build a picture of what the burden of these diseases look like. You had it in your slides quite nicely, the incidence of the disease, how many of these, and that's sort of how many of these people, how many people with these conditions are born every year. It's as simple as that, but people have collected it. What's the prevalence? How many are living with it? And what's their life expectancy? Because then once we sort of know all those pieces of information, we can start to put together the kind of data that Chris has presented today. And I remember one particular challenge when we're working on this. You said to me, I think Michelle said it as well, you know, can we do some sort of survival curve? I'm thinking, I don't know, we've got such a patchwork of data here. How are we going to make that work? Let me have a think about it. And I'm so glad that you sort of convinced us to do that, talked us into doing it, because we were able to sort of piece together all the different conditions with different life expectancies, and highlight that this population collectively, what their trajectory looks like relative to the general population. And I think that curve that you presented today really shows that and really helps to put this as a priority. And just one last thing I'll say about that, because it's not just about the life expectancy. Michelle talked a lot about all the different symptoms that people with these conditions live through, and that's important to us boring old economists as well, because it captures a very important metric, quality of life. And I think if there's one thing that we can do, going forward, is really try and capture and quantify that burden in terms of the quality of life. And obviously we want to try and improve that with the kind of treatments hopefully you're talking with Nick about. But like I said, challenges, but ultimately very rewarding, and thank you for inviting us and allowing us to work with you guys.
Thanks, Dom. So to Meg now, so how important is evidence like that presented in the new paper for the work of the CDI?
It's hugely important. I think for the first time, being able to quantify this collective problem and the collective need that's associated with the problem of our community is really a huge enabler for advocacy. And we've mentioned that a few times today already. Up until now, this significant problem has really been hidden in the fragmentation of that isolated consideration of individual rare conditions. But now that we've got these statistics and this paper has uncovered these numbers, we can't ignore them anymore. We can compare them to much better known, better supported, better funded diseases. We have a really strong case for change. And Dom's mentioned the survival curve, and I find that graph incredibly powerful. I use it all the time in presentations. And one of the things that every time I look at it strikes me is that survival curve hasn't changed. If you look at progress made in other chronic diseases, pediatric or adults, there's been improvements in survivorship. There hasn't been improvements in survivorship for the childhood dementia disorders. So I think the collective consideration and the outcomes of this study really do give us that tremendous case for what we're trying to do here at Childhood Dementia Initiative. And I think also having the paper published in such a widely read publication is going to help us raise awareness amongst new audiences around the world, which is great, and also bring credibility to this approach of the collective consideration, which is great. But also, as a mum, so it's incredibly important for Childhood Dementia Initiative, and that's, why we've done it, and it's the foundational piece of evidence. But, I need to also point out as a mum how I find this just so tremendously validating, and all of the work that's come since, of the experience that I've had, that I've observed others having, and to finally start to see some recognition for the challenges that our community faces, and using this as a tool to do that is hugely, hugely powerful.
Great, thanks, Meg. We've got 5 questions now, so I think I might start working through them and come back to some of my questions at the end. So we've got a question from Carissa Bartelson, who's a researcher in Adelaide. So when targeting shared disease mechanisms across multiple types of childhood dementia using therapies, is there a basis for a single clinical trial which consists of a cohort of children with different diseases, or would it need to be multiple trials for multiple diseases? Is it feasible to combine diseases for clinical trials in this way? I can jump in here and say that there is one example ongoing at the moment where there's a therapy that's being trialled for Niemann-Pick C, Tay-Sachs and Sandhoff disease all in one trial in a basket trial design. But that's really the only example that I know of. So I'll turn it over to Nick and Michelle if you have any comments on that.
I'll jump in, Chris. I think it's an excellent question and is probably limited largely by the structure of how clinical trials evolve and are operationally delivered within the global community, and in many cases they're delivered by a sponsor who is developing a therapy. It's come from the researchers, but then enters a translational mechanism usually, which is being supported by a company who wants to try and roll out and deliver that therapy. And that's subject to a whole bunch of regulatory processes, which are really important as we develop therapies, for those processes to be in place and to ensure that everything is being performed in an ethical and appropriate fashion and a safe fashion. But it's also somewhat restricting, because it's much easier to look at a single disease, to look for a single answer. And that's been the basis of how most clinical trials have rolled out, across history. And for diseases where there are lots of patients, that's not such a difficult thing to achieve, because there are plenty of patients who can enter those trials. For the childhood dementias, again, as Meg alluded to, the fragmentation of these disorders, the consideration of them as singular entities, has meant that first and foremost, that there's been less appetite to even look at therapies for these diseases. And of course, to group them together has been not even a consideration that has been, or not a possibility that's been given any consideration until very recently, with that one trial that Chris is talking about, of which those disorders have similar mechanisms underpinning them. And that's perhaps one of the strongest arguments for grouping these diseases together and looking at the mechanisms, because if we can show commonality of mechanism, as we can across many of these diseases, it underpins the rationale to group these children together in a singular trial. So I think it's a future endeavour to pursue, and I think we will look and see more of that happening in the future. And certainly it would be one that those of us who are involved in this space would support, across a range of conditions.
Anything to add, Michelle?
That approach is used in cancer clinical trial therapeutic development. So yes, but there's a long way to go in terms of clinical trial readiness in childhood dementia. And I think that's why we're all very passionate about getting to that point. And I think understanding trajectories, how conditions change over time, discovering biomarkers, disease mechanisms will all be enablers and opportunities to get to that approach. So even though sometimes it feels like a single research project can be very obscure and not clinically relevant, it can be a part of a clinical of a jigsaw puzzle building together, and I think all those little pieces are going to be important.
Yeah, changing track a little bit now, back to Renee. What's the most helpful thing us health professionals should know when they're coming into your home?
I guess the most helpful thing is to understand that parents do become experts. As much as we don't have the degree, we do need to be respected in the way that we know our children better than anybody else. And just to echo what Meg said, the validation and letting us have that little bit of hope, not writing our children off because they have a terminal disease, but encouraging us to keep moving forward and keep fighting for our children, and knowing that you're on the same page is really helpful.
Yeah, that's great. And I'll also just point out that we do have resources on our website for health professionals about how families would like to be treated, and insight into that. And we'll keep updating that as we gain more insight as we go along. So next one, from Vicky Barry. If we want to change the stereotype of dementia affecting older people, we need to consider comparison to young onset dementia, those diagnosed under the age of 65. This cohort is also underserved. So Michelle, do you want to tackle that one?
I agree. And I think there's many areas of medicine that require focus. And I think what we know is in an aging population, what the cumulative impact of environmental factors can be for later onset dementia, but all of those are modelled from midlife onwards. So smoking, pollution, obesity, alcohol intake, head injuries. They're all important for developing prevention approaches for aging dementia. But I would ask the question that we need to take it further back. And if we can understand what happens in early life, that will be important for interventions throughout a life course to have an impact in dementia. So it's only has synergies and benefits across the spectrum. I think that some of the insights in early onset dementia will be very relevant, because a lot of the child dementia disorders are monogenic, and so that is why they are so severe and have impact at a young age. Whereas if you have if you're just a carrier, that could be why you're vulnerable to additional cumulative insults through the life course. So that could be part of the mechanism of dementia in midlife. So any insights that are understood in early life through the severe end will be relevant to people that have what you would call a milder phenotype, because it's not, but it's just that it's manifesting at a later age, but there's going to be commonalities there.
Chris, can I just add on to that also? I think from a systems point of view, the younger onset dementia population are hugely interesting to us at Childhood Dementia Initiative, because I think the challenges that some of those or that population face will be more similar to those that children and their families face, in terms of the way that the whole family unit is impacted, stage in life that the whole family unit might be at, accessing systems that are different to those that will be accessed by those with ageing dementia, such as the NDIS and the non-aged care health system. So I think that cohort of people with dementia are of huge interest to us at Childhood Dementia Initiative, and I'm also quite surprised at how underserved they are and how infrequently we really do hear about their challenges. But I think we can learn a lot from them.
Yeah, great. So I've got a question next from Tony White, who's a researcher from Queensland. Are there any sporadic forms of childhood dementia? If not, why not? Is it because sporadic dementia takes a long time to manifest? Many adult dementias have sporadic forms. There is air pollution-driven dementia changes in children's brains in Mexico City, but that's the only example I know of. So I guess talking more about the acquired dementia rather than genetic forms of dementia.
Yeah, I mean, I think Tony raises a really important point, and Michelle touched upon this when she was talking about disease genetics versus environment and the multiple factors that impact a disease course. And I think that it's a difficult question to answer with the knowledge that we have, but certainly there are acquired forms of childhood dementia, vitamin deficiencies and things like that, which are ostensibly sporadic. However, across the genetic-based dementias, and we also need to consider that in many cases, as Michelle alludes to, it's a gene dosage effect. The majority of the childhood dementias are monogenic, a single gene which is knocked out and dysfunctional, which results in a disruption, a perturbation of the cellular function, and therefore consequent disease. In the adult onset dementias, some of those are monogenic. There's a single gene that has been pinpointed as a major player in that disease course. But in many cases, it's a mixture of our polygenic, makeup of different changes in different genes that may be 5, 10%ers, half percenters that accumulatively have an impact. And on top of that, of course, then are the environmental burdens, and both accumulative and otherwise, that impact our disease course. And it's important to recognise that that spans the childhood dementia spectrum as well. We have children with certain forms of childhood dementia, and indeed this is fairly common across many of the disorders within the childhood dementia group, where they may have the same genetic change, the same genotype, and indeed the exact same pathogenic mutation in the gene, but behave very differently in the way their disease presents within that childhood dementia disease course. And indeed, some of those children show precipitous decline outside of the expected norm, whereas others show a more attenuated form of disease. And some of that we believe is due to the change in the gene and the impact that has on the disease. But in some cases, there are other factors, whether they be polygenic or epigenetic factors. Inflammation is a very strong area of interest across the childhood and indeed the adult dementia field. And we know that certain children with certain childhood dementias who become unwell with systemic illness and develop cerebral inflammation and an increased inflammatory burden can show a decline in disease as well. So those factors are at play across the spectrum, and I think Tony raises that point really very well. And we need to consider how we might tackle some of those disease-modifying pathways. They may not be the primary cause, but they may have a very significant impact on both quality of life and indeed on attenuating the rate of degeneration for young people with these dementias.
Yep, just conscious of the fact that we've only got 9 minutes left, so we might be able to squeeze another couple of questions in. Kirsten Furley, who's a clinician in Melbourne, do you have data on the investigations and diagnostic yield for these children to inform clinical care potentially reduce diagnostic odysseys? Perhaps moving to genomics first line. We need data to appeal to Medicare to support funding for genomics. So would you have any thoughts about moving to genomics as first line diagnostics?
There's a huge body of work looking at newborn screening and genomic newborn screening, and the childhood dementias are very much a part of that picture. And there's a lot of work that we need to do to advocate for the inclusion of those conditions within those newborn screening platforms. And that's something that we're very focused on. I know Michelle has some activity in that area, as many do around Australia, and we're very keen to push the childhood dementias into that space, because it does make a difference. And indeed, diagnosis in pre-symptomatic children, those who are not symptomatic, is critical to outcomes for all therapies, whether they be supportive or targeted disease therapies. So yes, is the short answer.
Struggling to pick a final question. Okay. Helen Metzger asks, as you develop clinical trials for these populations, will you involve the families as part of your research team from concept to implementation, so that research addresses topics that are most relevant to their needs?
That would be wonderful.
That's the ideal, isn't it?
Yeah, I had I was introduced to a concept that I absolutely loved by a group from the Cerebral Palsy Alliance called CP Quest. And I was strongly, I really liked the idea, and the tagline for that is "Nothing about us without us." And I think that's exactly what should be done. And what I've been, I think as the science improves and there's so much happening in the lab, which is absolutely critical, that scientists and clinicians and families need to be working together, not in silos, so that as therapies are developed in test tubes and in animals, we are already working and thinking about that clinical trial and collating data so that we know what is happening before a therapy is administered so we can compare it afterwards, because the challenge with a rare disease is that you're not going to have large data sets of natural history, which is, you know, what happens over time. So we can only do that if we all work together. And I think families understanding what the impact of a therapy is and what is meaningful is absolutely important, and knowing what to measure so that we have some objectivity, so that we have evidence to say this would benefit other people is going to be important. So, but it's a challenge given how much pressure and, you know, the stress of living in this with a child with dementia as well. So we have to be respectful and do it in a way that is respectful and appropriate.
And just to add to that, at Childhood Dementia Initiative, we're working with families in deep consultation to understand what the key challenges are, what the key areas of need are, in order that we can then share that information with others who are working in this space. And one of the projects we're seeking funding for at the moment is actually development of research priorities in deep consultation with families. So hopefully the work that we're doing in bringing together families, amplifying their voice, and really documenting and publishing the common needs will help in ultimately development of clinical trials. What are the endpoints that we're measuring? What are the things that are really important to families? And I know I've seen this in the space of the condition that my children have. Often the thing that's being measured is the preservation of or the improvement of cognitive ability. And often families will report, actually, if we could address sleep or behaviour or some of these other quality of life issues, that would have a tremendous impact on our quality of life. So it's just important that we provide that conduit, I suppose, of the family voice.
And it's not just about in the clinical trial, because I think a clinical trial provides a set of data, but it's not applicable to everyone living with a condition or affected by a condition. So research doesn't stop once the clinical trial ends. It continues, and that can be very advantageous in providing additional very important data for regulators to make decisions and for healthcare providers to understand the expectations of a therapy for an individual and how to improve how we treat people. And just to, you know, we could say this will improve cognition, but we won't say if it improves sleep. So we need to understand a broader impact of therapy. So the only other thing to say is that the NHMRC have clear guidelines on consumer involvement in research, and it can't be tokenistic, and it's best done as studies are conceived and developed, and it's a journey, and it's from the beginning. But I think, you know, a priority setting exercise where we know what the priorities are is a good place to start.
And as Michelle said, we're treating people, not diseases, and we need to focus on what's meaningful for those people, for those patients, and for their families. And we can all think we know what that is, but the people who know are the ones we need to involve and work in partnership with, so that we're all getting to a point where meaningful outcomes for patients and families are being delivered.
And
Did you have something to add?
Sorry, Chris, I was just going to add all this, the stuff around the meaningfulness and the quality of life, and Michelle mentioned about regulators, but it's really, really important for reimbursement agencies as well to make sure that, you know, the interventions ultimately are accessible to patients, which is really what we want one day and hopefully the not too distant future. So the better we do that now, the better it will be then.
Yep. I think that's a great note to finish up on today. I had more questions to ask, but we've run out of time. Thank you so much to our panelists today. Thank you for all of your time and all of your input into this study as well. And to Renee for giving the family voice. And thank you to the audience for joining us today. I do have another slide I'm just going to share. If you have any questions, there's my email address on the screen. Head over to our website for information on how to get involved for families, for researchers and health professionals. There's a separate page for each group. If you go to the Join Us menu, you'll also find ways to donate to help us to continue this important work. You'll see a beautiful photo of Renee's gorgeous kids there on the screen. And finally, there's Isla and Jude with their faces painted for Childhood Dementia Day. Thank you all for joining us. Wishing you all a happy holiday season, and I hope to see you at some more webinars in 2024. Thanks all. Bye.